Good evening, and thank you for inviting me to this presentation. And we will continue with this. Chemotherapy will have minimal role in the era of precision medicine, and as you just saw, Professor Cameron, he was with yes, and I was in the other side of the coin, so I need to defend my part. So initially, the precision medicine was something that came directly from the National Research Council, and this is from part of the Academic National of Science. And this was a real necessity to change the codes, the ICD codes, creating a new taxonomy of the diseases. And this is why, because we have this taxonomy for almost more than 100 years. And with the knowledge of genomics, we found that there are multiple diseases from one of the single diseases what used to consider before. Why now? Because all of these urgent needs to understand better the phenotype and genotype correlation. This new taxonomy really will change completely the vision of our disease and the way how we manage and how we treat not only the cancer. And the proposal of this toward precision medicine is to do a multiple rationale of clinical trials. This is a fantastic paper. It's almost 200 pages. And of course, our society in United States, ASCO, came back immediately after with a precision oncology overview, and there are multiple task forces working currently in this aspect. So somatic mutations in cancer is something that seems to be very difficult to understand, but really we have 95% of the cases are single base substitutions. We are talking about base substitutions. Deletions and insertions are rare, rearrangement and gene copy numbers are very rare. So basically when we are looking across all cancers, and this is a wonderful overview looking for all of the somatic mutations. Our tumor that we are investigating, breast cancer, is actually not the most mutated. We have in the outliers one of the extremes, lung cancer and melanomas, and the other, the leukemias. So you can see here in this table the multiple dots, meaning the number of mutations, and the horizontal red bar is the median. So we can say that the breast cancer is not one of the most mutated. But what we need to know about this spectrum of the mutations, that not all the mutations means the same. In other words, we have a gatekeeper's mutation, initial mutations, where we found in many of patients, some persons without cancer. And this is a case of colon cancer with the APC, adenomatous polyposis cancer. And after that, following the two-hit theory or hypothesis, we have the second mutation. And the second mutations provide different characteristics to the growth of the cancer. And this is what we call clonal expansion, and this is due to the pressure of the medium. And this is a real driver mutation. So the driver mutations confer a selective growth advantage to the cells, and that's why we characterize this as a cancer. So as Dr. Cameron explained before, there exists a phylogenetic tree of these mutations, and we can see it in this in kidney cancer patients. Most of the diseases are coming from one gene. In this case is VHL, von Hippel-Lindau. But after that, we can find that this mutation has multiple other shifts, frame shifts, and have a primary, secondaries, private, public type of mutations. So this make a consideration. If we want to know what type of mutations this patient with cancer has, we can say that there are approximately 4 different types of genetic heterogeneity of the tumors. So we can have a patient with a pancreatic cancer and liver metastasis, and this confers the first mutation, intratumoral heterogeneity in the primary tumor. But the part B, you can see exists that intermetastatic heterogeneity between 2 metastases in the liver. And to add more complexity, we can have intrametastatic heterogeneity within both metastatic lesions. And of course, all the patients are different and there exists the interpatient heterogeneity. So this is getting very complex, even that is a very simple, the type of mutations, the amount of the mutation and the constitution of the mutations are very complex. And what happened when we hit one of these drivers? Well, we have the case of HER2 positive breast cancer patients treated with anti-HER2 trastuzumab, or one of the patients with the EGFR mutated and treated with the lotinib or gefitinib, and a patient with this 55% of mutations in melanoma, BRAF B60, B600 with beramifumab, and patient with the RET, oncogene, and lung cancer. So when we treat this patient with the appropriate drug, appropriate driver, this is the combination of the right drug with the right target, we are not curing these patients. We have a response. Most of the times are minor, major responses, but we are not curing this patient. This patient might achieve a small type of response, and indefinitely all of these patients will relapse and they are going to die. What happened in the breast cancer spectrum? Well, we have numerous genomic alterations in breast cancer. We know that the most common, the PI3K mutations, depends the stage of the cancers. These mutations behave in different ways in early stage than metastatic disease. Depends on the phenotype. And HER2 PI3K mutated in HER2 positive breast cancer patients confer resistant, and this has been reflected in recent papers in neoadjuvant. So it's a real, not a true drivers that we are thinking that we are targeting. The true drivers constitute a very small percentage. It's about a 5%. And you can see all of these rare genomic alteration. There is a high frequency of rare targetable genomic alteration. So look at this. These are all druggable mutations. So think in the United States we are seeing between 230,000 to 250,000 the incidence of breast cancer. If we have a 2% of incidence of these druggable mutations, it's approximately 4,600. It's the same number approximately of CML patients. CML now is a curable disease. The median survival of patients with CML in the United States is 25 years. And the 0.5 incidence of druggable mutation is about the same of APL, leukemias that they're actually cured. So the point is we need to find out all of these rare mutations and start treating all of these patients the same way that our colleagues in hematology are doing, and they have a great success with the CML and APL mutation. And let me show one of our colleagues, André, presented in France, and this was already published, Saphir-1, and he collected data. It was a giant effort in a very short period of time. He collected 423 patients. This is sequencing DNA to personalized targeted therapy, 18 centers across France. 423 patients signed informed consent, obtained a fresh biopsy of 404 patients. 67% of these patients get some targetable genomic, and 25% of these patients participated in one of the clinical trials with the genomic driver mutations. But if we look from the top to the bottom, we have only 12% of these patients that had biopsy were able to participate in these clinical trials. So these 48 patients were heavily pretreated, patients that has multiple lines of chemotherapy with high aggressive disease, and this was the genomic alteration, 16 different regimens for the most common abnormalities that we are seeing in breast cancer. And this perhaps is the most conclusive part of this study. If you see that the 48 patients treated with the therapy match of genomic analysis, only these 12 patients obtain a response. So if we back from the 404 patients and we have a 12 response, that means we have only a 3% of these patients get some benefit. digging and doing these targeted therapy or genomic driving trials. So how we can increase this rate? Well, this, as Dr. Cameron mentioned and Dr. Apro mentioned as well, I have 2 slides only, please. We have breast cancer is a very, we can divide like an orphan disease, and it has multiple subtypes. Can I have 2 slides, please? The way that we are treating now this patient is a concept that Fabrice mentioned, is a fragmentation. So we are treating or developing, providing drugs just for these abnormalities of this patient. Oh, thank you. I need to click there. Thank you. So this is the first part that is fragmentation of the rare genomic entities. So the first thing is the alliance. The first thing is, the fragmentation, the way that we are working now. The second type is the alliance, that is using the multiple clusters of these rare genomics. But perhaps the most important is to start thinking in using the bioinformatics and multiple computational models to treat this patient. That is the goal of this trial. So the approach of personal medicines, number one, we need to greater involve in neoadjuvant clinical trials. This is the way and biological model that we will learn, an ability to obtain multiple serial tumors, reconsider the real risk, and this is for all companies that they are willingness to provide drugs for 1 or 2% of the population. So we need to do multiple small trials, and of course start using the power of this technology. So blocking one road is not enough, we know that, and there is how we apply all of this molecular diagnostic is not under standard of care, but under control clinical trials. And of course, I never played to whack-a-mole, but many oncologists are thinking that to play nowadays in the genomic area of personalized medicine, you need to play this type of game. For me, whack-a-mole is whack-a-mole, something that we enjoy a lot of in Texas from Mexico. So future challenges, we need to know, the first step is to identify the oncogenic driver. We cannot find the oncogenic drivers in the most common Foundation 1, Caris, Lapative, Agendia. All of these tests doesn't provide information if this is oncogenic drivers. This is a great mistake that many physicians believe. So how to predict and overcome the resistance, how to integrate other biological systems, and how to translate this to early breast cancer. And of course, how people will access to this terminology. So in terms of chemotherapy, we have a minimal role in the area of precision medicine. No at this time, maybe in the future. Thank you so much.
Next issue of controversy, it is endocrine therapy in premenopausal women. Is tamoxifen still the standard? And it will be between Professor Ann Partridge from USA and Professor Eric Wiener, also from USA. Professor Ann Partridge is a professor in the Department of Medicine, Harvard Medical School. She is an active medical staff in the medical department, Dana-Farber Cancer Institute, USA.
Good afternoon. My answer to the question posed is yes, and I look forward to debating my esteemed colleague, Dr. Eric Weiner, with whom I'm quite accustomed to arguing, although given that he's my boss, I usually do what he says. You can see here the effects of 5 years of tamoxifen in women with ER-positive tumors by age. And for women less than 40, you can see a hazard reduction in the event rate of both recurrence and death of somewhere between around 40%. And for women in their 40s, it is also quite substantial. And it's, of course, substantial for women as you go up in age. And there is no evidence for heterogeneity and effect of tamoxifen by age or by administration of chemotherapy. There is no doubt that tamoxifen is a life-saving drug. And even when we stop tamoxifen after 5 years, which has been the standard now for several decades, even among women who are less than 45, as you can see here depicted from one of the latest overview publications, in women with ER-positive disease, even among almost 80% who received chemotherapy, not only do we see a substantial risk reduction in terms of breast cancer mortality and any deaths from the receipt of tamoxifen at the 5-year mark, but we see that carryover effect where we don't need to continue tamoxifen and yet the curves keep separating. Again, tamoxifen, reducing risk of recurrence, saving lives. And there is concern that the competing drugs, such as aromatase inhibitors, and this is from the ABCSG12 trial, which was all premenopausal women, may not work as well in all patients. There are some evidence, and this has been seen in the ABCSG12 trial, and it was suggested in the ATAC trial, that in obese and overweight women, which is unfortunately a growing segment of our population, the aromatase inhibitors may not do as well in terms of disease-free and overall survival, as you can see here with statistically significant p-values in the overall survival category. And what about extended duration? Well, we have no data yet for extended duration with the competing options beyond tamoxifen. And we do now know that 10 versus 5 years of tamoxifen improves both cumulative incidence of breast cancer events or recurrence and breast cancer mortality from both the ATLAS and the ATOM trials. The ATOM trial is depicted here. And you can see very, very consistently across these two large national and international trials in the UK as well as internationally that there's a 4% reduction in the risk of recurrence and there is a 2% reduction in breast cancer mortality from taking an additional 5 years of tamoxifen. Well, along comes text and soft, and this is the schema, and we all know the results. And the results were text showed a statistically significant improvement in disease-free survival for women who were every one of whom had received ovarian function suppression, and the women that got the AI trumped the women who got the tamoxifen, but there was no overall survival advantage. In fact, if you look at the curves for overall survival, which is on the bottom right corner of your screen, the tamoxifen group looks a little bit better. So it's hard to imagine that there will be an overall survival advantage in this whole population. And what's the cost? And you can see here listed the adverse effects on text. And recall that they're all on ovarian function suppression. The most frequent side effects, hot flashes, musculoskeletal symptoms, hypertension, lots of depression in all of these women on ovarian function suppression. Osteoporosis, which of course we know is worse on exemestane than it is on tamoxifen. And then there were more fractures, musculoskeletal symptoms, vaginal dryness, decreased libido, and dyspareunia on the exemestane. And this is a class effect in the aromatase inhibitors. What about GYN cancers? Well, there was no statistically significant effect. There were numerically a few more, but they were so few in the premenopausal group for women on tamoxifen that it didn't bear out in terms of having any statistical significance. And then in terms of overall quality of life, it was the same. And there were different symptoms, but quality of life was the same. So that's not a reason to choose one over the other. Now along comes the SOFT trial. And I will remind you, for those who saw it at San Antonio, have heard the results and heard Prue Francis give a wonderful presentation. She started her conclusions with tamoxifen is still a very viable option for premenopausal women with breast cancer. And that's because this was a negative trial overall. The SOFT trial was negative overall. Does everybody hear me? A negative study. We learned a lot, but it's a negative study. And that's because for the entire population, the primary analysis from SOFT, there was not a significant difference for women who got tamoxifen compared to tamoxifen plus ovarian function suppression in terms of the primary outcome, which is % alive and disease-free, and you can see the numbers here. And amongst the women, the vast majority of women in this study who were premenopausal and did not get chemotherapy, again, there was no difference in disease-free survival, and of course, no overall survival advantages to date. And here we were more able to see the cost of toxicity of therapy because not every group got the ovarian function suppression, and so we could really see the difference. Importantly, there was non-adherence, and people did not persist with the ovarian function suppression. You can see the numbers there. By 3 years, almost 1/5 of women had stopped ovarian function suppressant. And we all know in our practices that it can be a really tough treatment, particularly on very young women who are not used to even remotely thinking about hot flashes or other dyspareunia and problems like that. In terms of the provider-reported symptoms, again, this report of depression, in fairness, this was also found in the tamoxifen-only group. I'll let Dr. Weiner play with that, but only 4% were severe and 5% with an increase in overall ovarian function suppression. And there was clearly an increase in menopausal symptoms, osteoporosis, and insomnia in the group that got ovarian function suppression. Amongst the patient-reported, again, no difference in the global quality of life, but of course we know there are ceilings on these scales, and they're really designed for a sicker population in general. But the endocrine differences were quite profound in the group that got ovarian function suppression, and they were less pronounced after 2 years. But let's just torture people for 2 years, and then they'll feel better. I'm not sure if that's the best answer. And it might also be that they were less compliant. Again, almost 25% stopped taking the ovarian function therapy. And of course, this is an intention to treat analysis. You can see here the treatment effect by cohort, and the groups that are the blue and the red, which are the 2 groups with the ovarian function suppression, clearly are shifted to the left with regard to all of the usual suspect side effects from ovarian function suppression, and then, of course, the addition of the AI, with the bone and joint pains being the most predominant. But you can see the hot flashes, the sweats, the loss of sexual interest, the sleep disturbance. A coping effort was a wash, and treatment burden overall was similar and the worst in the group that got the ovarian function suppression. So I'll stop there, and I will conclude with tamoxifen still has a very safe and comfortable home for our premenopausal patients with breast cancer, and I'll let Dr. Weiner debate that. Thank you.
Thank you. We have now the other point of view, or no, by Professor